Hello, and thank you for joining us. My name is Justin Meyer. I'm the Senior Director of Development for Neuroscience Philanthropy at the University of Pittsburgh. We're excited for today's Pitt Health Academy discussion with Dr. Lopez, providing us a comprehensive update on Alzheimer's disease. Just a little bit about Dr. Lopez. He is a nationally and internationally recognized expert in Alzheimer's disease. He's the Professor of Neurology, Psychiatry, and Clinical Translational Sciences, the Chief of Cognitive and Behavioral Neurology, the Levidow Pittsburgh Foundation Endowed Chair in Alzheimer's Disease and Related Dementias, and the Director of the Alzheimer's Disease Research Center at the University of Pittsburgh. Besides that, he's an amazing human being with an incredible drive to find new ways to treat and hopefully one day find a cure for those suffering with Alzheimer's disease. If you have any questions or comments after listening to today's presentation, please email me at jrm233@pitt.edu. As for that, Dr. Lopez, thank you, and please take it away.
Thank you, Justin, for the introduction. I'm going to start showing something about the epidemiology of dementia and Alzheimer's disease. We think that there are approximately 6.7 million Americans aged 65 and older living with Alzheimer's disease. And we expect that that number will reach 13.8 million if we don't find a cure or something that can slow down progression. There are about 10 million new cases of dementia diagnosed annually around the world. And the most common form of dementia is Alzheimer's disease. I would say 80 to 20%, 80% Alzheimer's disease, 20% the other dementias. But it has a tremendous cost on society. This is just to give you an idea about the prevalence of dementia in the community. This is from the cardiovascular health study. This was a large epidemiological study where we tried to establish prevalence and incidence of dementia in a large cohort. And you can see that the prevalence increases with age. And after age 85, practically half of the population met criteria for dementia. More women than men, but you need to take into account that women live more than men, approximately 7 to 8 years. What you are seeing here could be just a survival effect, but anyway, the prevalence after age 85 is huge. What are the risk factors for Alzheimer's disease? And I would say the only risk factor that we know is age. We know for sure that the older we are, the greater the risk. There are some genetic markers like the ApoE4 allele, but that explains approximately 20% of the cases. Then there are possible risk factors, as I mentioned before, women, but difficult to tell when women live longer than men, and the most important risk factor is age. Cardiovascular risk factors, cerebrovascular risk factors, history of head trauma, family history of dementia, family history of Down syndrome. Those are possible risk factors. And then we have some protective, some protection, and mainly coming from a lifestyle. We know that many studies show that moderate alcohol intake decreases the risk of Alzheimer's disease. It doesn't mean that you are not going to have it. When you decrease the risk, it means that you are going to have it, you will have it, but maybe later. A good diet, Mediterranean diet, physical activity, cognitive activity, all these things are linked to a lifestyle. So people that are eating healthy, most likely they exercise and they remain cognitively active. So all these factors are good for you, but it doesn't mean that you won't have it, but if you have it, you will have it later. There are some other risk factors that are related to when they started. And we know that early life and education in early life is critical. So education is give you sort of a cognitive reserve for having the disease. in midlife, hearing loss, hypertension, obesity, excessive alcohol intake. This is not moderate, it's excessive alcohol intake and head injury are factors in midlife. And in late life, smoking, depression, social isolation, physical activity, diabetes, and air pollution. So all these are factors that are related. Those are risk factors that are related to when they start, when they are diagnosed. So this is the way that we go. We have things that are bad for us, and we have things that are good. So we are continuously compensating. So we have some things that increases our vulnerability to have Alzheimer's disease, and there are things that increase the compensation or increase the protection. In this slide, what we see in red and yellow, this is just the relationship between chronological age or age and the cortical thickness, which means is is gray matter, neurons. And you can see that as we age, we have a decreased cortical thickness, or we call it volume loss, and it's basically it's the whole brain that is affected. So this is, I would say, that's why we say age is the most important risk factor, is because age is causing this vulnerability. We have a decreased volume loss, decreased cortical thickness, and that's what in some ways open the doors for bad things that happen to us as we age. So, but the brain structure is not only affected by age. There are things that are happening with age, and I put here hypertension because hypertension has an effect on brain volume, and this is something that we can avoid. So a proper treatment of hypertension will have a good effect on brain volume. And then you have in the middle Alzheimer's disease. Those are the most the most important areas affected by Alzheimer's disease. So all these things are happening in the brain. You have an effect of age. In people with Alzheimer's disease, you have Alzheimer's disease, and then if you have hypertension, hypertension has an effect on your brain. Now, these are the good things. Here, red means good. So, and this is from the cardiovascular health study, and where we found that people who were walking more than 72 blocks per week had good brain volume, especially in the prefrontal cortex and temporal cortex. And we follow these individuals over time, 5 years after the scan, and we found that those who continue being active had decreased risk of dementia. So these are things that are good for us. And this just give you an idea. When we are studying risk factors for dementia, and this is from the cardiovascular health study, you can see on the right the ApoE4 allele, and I told you that that genetic marker can explain about 20% of the cases. And when you put all the risk factors together, it's the most important. So, but then you have ventricular volume. So the brain structure and things that are affecting the brain structure are also risk factors. You see there, education level, it decreases the risk. But the most important message of this slide is that something that explains only 20% of the cases is the most important risk factor when you put all of them together. This is a complicated slide, but I will explain it to you. So Alzheimer's disease is a neurodegenerative process. And neurodegeneration is a term used to describe the progressive loss of a structure or functions of neurons, including death of neurons. you can see on the left the pyramidal neurons. So in early stage Alzheimer's disease, you have those, the black figures are neurons. In this background, it's a green background. And then in late stages, you see fewer neurons. Why we are losing the neurons, we don't know. So which one is the initial trigger for this process, we still don't know. But there are things that are happening. We know there are multiple things that are happening when we have this condition. So, for example, we order an MRI of patients with Alzheimer's disease, and we don't see strokes. We don't see anything that can explain the cognitive deficit. But if we do an FDG PET, we can detect areas of the brain that have low metabolism. So that is indication of neurodegeneration. The other pathological hallmark that we have is amyloid deposition. You can see there on the right, and we can detect now with technology. So the technology to detect amyloid in the brain was developed by Dr. Bill Clank and Chet Mattis here at the University of Pittsburgh. And the first tracer was called Pittsburgh Compound B. And that changed the whole approach to research studies in Alzheimer's disease, because it opened the door to measure outcomes. So knowing how much amyloid you have in the brain when you use medications that are anti-amyloid, you can measure this over time. So this was, I would say, a significant contribution of Dr. Clank and Dr. Mattis to mankind, I would say, in general. Then the neurofibrillary tangles, those are lesions that are happening inside the neurons. The amyloid plaques are outside. The neurofibrillary tangles are inside the neurons. And we have now a tracer that can detect the neurofibrillary tangles. The other thing that happens in the brain of people with Alzheimer's disease is inflammation. And around the plaque, the amyloid plaque, we have an inflammatory process. Now we have an inflammation tracer that we can use and detect inflammation in the brain of this patient. So gradually, we started with an MRI and an FDG PET, and now we are moving forward with technology that can detect multiple pathologies in the brain. This has been a significant step forward in our field. This is just to give you how complicated is the study of Alzheimer's disease and related dementias. I mentioned previously that amyloid plaques are important and neurofibrillary tangles are also important, but we also are losing cholinergic neurons. And the current treatments for Alzheimer's disease include the cholinesterase inhibitors. So that's another pathology that we have in the brain of these patients. There is also synaptic degeneration. There is cortical TDP43. That's a strange protein, and it's in about 30. It's present in about 30 to 40% of the Alzheimer's disease cases. But at the same time, this protein is present in people with other types of dementia, especially the frontotemporal dementia. We have also cortical Lewy bodies, and the Lewy bodies are the hallmark for the diagnosis of Parkinson's disease. So there are many pathologies that are happening at the same time that we are still trying to understand when they start and what's the effect that they have in the clinical progression and symptoms of our patients. So here, just to show you what happened over the past 120 years, we know that Dr. Alzheimer described the patient in 1901. It was a patient in a psychiatric hospital that had Alzheimer's disease and Lewy bodies in the brain. And then later, his boss told that this condition should have your name. So that's why we have now these patients with amyloid deposition and in the brain associated with tau proteins. They carry the diagnosis of Alzheimer's disease. And many things happen over the past century. We have the first treatments with donepezil, rivastigmine, galantamine, memantine. And you see, in 2004, it was when the Pitt compound B was reported, and we started doing this. And all the other, then very rapidly, the field has been testing multiple anti-amyloid drugs and anti-tau drugs. We are approaching, maybe by next year, we'll have 3 anti-amyloid drugs in the market. So the field is, I would say, is in an acceleration process in terms of treatments for Alzheimer's disease. This is what we have these are the FDA-approved drugs. They started with Tacrolimus in 1993, and then we were doing really well. Tacrolimus in 1993, donepezil in 97, rivastigmine in 2000, galantamine in 2001, memantine in 2003, and then it was a huge gap between memantine and aducanumab that was approved in 2021. In lecanemab in 2023, and we hope that donanemab, which is another a monoclonal antibody, will be approved in 2024. The first 4 drugs are cholinesterase inhibitors, and as I mentioned to you before, 90% of the neurons that produce acetylcholine, which is a critical neurotransmitter in the brain, disappear. And just going back in history, we can show that what studies that we did with cholinesterase inhibitors, and they have an effect, and they worked, but they were not magic drugs, and people were expecting to see something more relevant when we're treating patients with cholinesterase inhibitors. But they did what they're supposed to do. They slow down progression. These studies were done within a very short period of time. You can see there at 36 months or 130 weeks. We have done, in this slide, we have done a long-term study using whether the combination of cholinesterase inhibitors and memantine worked in the long run. And you can see that people on the combination of memantine and cholinesterase inhibitors had a decreased risk of going to a nursing home. And that means that in some ways they have a better quality of life. They were able to stay home for a longer period of time. And this was much better than those using cholinesterase inhibitors alone versus those that were taking they were not taking any medication. But you can see we were able to detect these effects of cholinesterase inhibitors and memantine when we examined these databases for years. So you see, this study, it took almost 17 years to put together the cohort. So that's what we expect to do with the new drugs. We want to see what happens in the long term. But cholinesterase inhibitors, they had an effect. It was modest, but slowed down progression. But what it was very important is that people had to take this medication persistently and don't stop. There is a point where you have to stop, but it's very important to take it, to be persistent with the treatment. This is a very is a way to show what's going on now. And you see there are many studies, phase 1, phase 2, phase 3. The pipeline has never been so busy and crowded. There are currently 187 trials assessing 141 drugs for the treatment of Alzheimer's disease. There are 36 agents in phase 3. There are 21. They are testing 21 pathological pathways. Remember, as I mentioned to you, we have the amyloid, we have the tau, we have inflammation. So there are drugs that are targeting those different components of the process of neurodegeneration. And we need more than 57,000 participants to complete all these trials. But this is very encouraging. You can see how busy is the pipeline. So in terms of the NIH is doing what it's supposed to do. Is funding, for example, you see less development of new molecules, but more development of non-pharmacological interventions. The NIH is supporting treatment of neuropsychiatric symptoms and also supporting interventions for caregivers. So you have less less new molecules, but more non-pharmacological interventions. And I think this is a good thing that the NIH is doing. As I mentioned to you before, that there were some protected effects, and people have been talking about the Mediterranean diet. That's something that can improve your cognition. But when you examine only the diet, this is a study that was done. It was a 3 years long study that tested a diet. There was plant-based foods, fish and olive oil, and there was no effect. There was no difference between the control group and the people having the diet. It's the whole lifestyle that makes a difference. It's not just only one thing. There was another big study that this was called the Cosmos studies, and see whether multivitamins and chocolate, cocoa, was able to decrease the risk of heart disease and mild cognitive impairment and dementia. It had no effect. It was neutral. So you can eat chocolate. There is no problem with that. Cocoa had no effect on cognition, at least improving cognition. But what was very important, that neither cocoa nor multivitamins decreased the risk of mild cognitive impairment or dementia. So it has an effect on cognitive measures, but what is really important, which is the syndrome, the cognitive syndrome, these two interventions had no effect. This is another busy slide, but just to show that practically all the prevention studies fail. And so far, we have 3 active prevention studies. The HEADS A3-A45 study, that study, we are recruiting for that study. That is with lecanemab, is one of the drugs that was recently approved, and that study is ongoing. There are another study with metformin. These are people without diabetes. Remember, metformin is a drug for diabetes. People without diabetes, and they are taking 500 to 2,000 milligrams of metformin. And the preventable trial is atorvastatin, is an statin, a drug that we use for hypercholesterolemia. And it's just the endpoints are incident mild cognitive impairment, dementia, cardiovascular disease, and mortality. So all those are prevention trials, but which is very I would say it's very sad that practically all the trials, all the preventive trials that we try have not worked well. In terms of, these are recent disease-modifying drugs, same thing. Early medications did not work. The Berubesestat, one of the study, the placebo did better than the control. One study was stopped because of the adverse events. And then in 2022, we have the aducanumab trials. There were two trials. One was positive, one was negative. And we can say that the CDR sum of boxes, SB, was the main outcome, and it showed 22% less decline, and that was the most important finding. The other, the ADAS-COG and ADCS, ADL were secondary measures. The gantenerumab and crenezumab studies were negative. Then the lecanemab was another large study that showed that that was also positive, and the CDR sum of boxes show 27% less decline. The ADAS-COG, which is another cognitive measure, is a secondary outcome, show 47% less decline. And the donanemab study showed 35% less decline with the primary measure, which is the IADRS, which is a composite measure of function and cognition. And the CDR sum of boxes was a secondary outcome and showed 36% less decline. As you can see, we are moving forward. Early studies were negative, and now more recent studies start showing efficacy. This is just to what happened with the lecanemab and the donanemab. At the bottom is the amyloid PET scan. Remember, I showed you the PET scan, the amyloid PET scan, that was critical to measure the outcome of these interventions. These two drugs were very successful removing amyloid from the brain. And you can see on top is the effect on the primary clinical outcome that I mentioned to you, is about 22% less decline and 27% less decline with the other. So there is a significant effect on the pathology, and there is a statistically significant effect on the clinical markers. So they did subgroup analysis of all these trials, and they were trying to see what happens, for example, how the people carrying the ApoE4 allele. Remember, I told you that is a risk factor. They explain about 20% of the cases. And what they found is that those patients with the ApoE4 allele had less response to the treatment. People that were age 65 or younger has less response. There was less response or less efficacy on Blacks and Hispanics. Same thing with people with a BMI of 30 or higher. And people with tau. Remember that I showed you the slide with you see the tau, the deposition of tau proteins. People that have a very, very high tau deposition did not do well. So these drugs are interesting, but we have now subgroups that they don't respond very well. And the most important side effect is the presence of microhemorrhages or hemorrhages in the brain, and edema, inflammation. So you see there, we call ARIA, amyloid-related imaging abnormality, and it's frequent in all these with all these interventions. So you can see with the aducanumab was up to 41%. And that donanemab is 37.4%, but it's the most common side effect of these interventions, and they are more frequent in the ApoE4 allele carriers. So the ApoE4 allele carriers have an increased risk of having ARIA. This is just another study. It was the total plasma exchange. This is a different type of approach. This is something that is not targeting amyloid or tau. It just has a different mechanism of action. And you can see there that the CDR sum of boxes show 71% less decline in the whole group. And when the group was divided in mild and moderate, there was a significant effect in the mild as well as in the moderate. In the moderate, it was 53% less decline. The ADCS CGIT is a measure that is done by the physician. This is the impression that the physician has on the patient. So you ask, do you think that this patient is doing worse or much better? And you can see there that as a group, it remained stable. That's why the effect size is, or the slow decline is 100% because it didn't move from baseline. And in the moderate, there was an improvement, and in the mild it was an improvement, and in the moderate it was a 64% less decline. So this is just to show you that there are many things that are being done to treat Alzheimer's disease, and these results are really encouraging. So who are the candidates to use medications? I mentioned to you there are many things that we have to take into account when we implement all these new drugs using monoclonal antibodies. And there are many studies that this is, for example, one example that they examined 28 million Medicare beneficiaries, and they applied the exclusion criteria used in the trials, and a total of 92% or 91% of the patients with Alzheimer's disease won't qualify for the treatment. So I would say about 10% of the patients will be in a good shape, good physical shape to receive these treatments. So who will have access to the treatment with monoclonal antibodies? So the patients, they have to have mild cognitive impairment due to Alzheimer's disease. So it means that in addition to do the clinical exam, we need to demonstrate that there is amyloid in the brain. So we need to do a PET scan or a spinal tap. All cardiovascular and metabolic comorbidities should be under control. So these are same exclusion criteria described in the trials. The MRI of the brain, it has to be free of acute or subacute lesions. And if they have macro or micro hemorrhages, those patients shouldn't have this treatment. The amyloid PET scan, as I mentioned before, you have to show the amyloid deposition. You need to be in a place with a neuroradiology expertise is available to review amyloid PET scans and MRIs. We need to have a process in place to manage the adverse events. And most importantly, the patients have to have access to experts who can determine the efficacy of the treatment. So after 1 year or year and a half with these medications, we need to assess these patients, and in those who are not responding, the treatment should be stopped. Now, here comes something interesting. Patients who cannot have an MRI cannot use these medications. And the problem is that we need the MRI to detect the micro or macro hemorrhages in the brain. So if we don't have the MRI, we cannot detect the most important adverse event of the treatment. Those people on antiplatelets or anticoagulant medication shouldn't receive the medication. And the reason is if they have a microhemorrhage or a macrohemorrhage, they can bleed and have a huge hematoma in the brain. We should also exclude those who are APOE4 homozygotes. So those are, they are carrying 2 copies of the gene. And I would say that is the consensus in large medical centers to exclude these patients. And the most important thing is age. What happens with those that are 62 or 63? Should they receive the medication? Our approach is that yes, but the VA, for example, is covering all these treatments, and they are not treating people age 65 or younger. So how is the process? This is to initiate the treatment. So first, we need to have a clinical diagnosis, and we need to make sure that the patient has mild cognitive impairment or very early Alzheimer's disease, and we need to do the APOE genotyping. We need to do a genetic study. Then we do the MRI to make sure that the patient doesn't have these lesions in the brain. Then we do the CSF or a PET just to confirm the diagnosis, and then we initiate the treatment. And we have to have, and all these patients have to have a very close monitoring. So finally, so what is happening now? So I think that we are entering in a new era of Alzheimer's disease treatment. More anti-amyloid treatments are coming. The implementation of the treatments requires well-trained personnel. There will be an increased role of blood and imaging biomarkers. So that's the other thing. This is the other thing that I didn't mention here is the development of blood biomarkers. That is coming, and there will be an increased role in clinical practice of blood biomarkers. There will be a combination of treatments. So patients now can be treated with a cholinesterase inhibitors or an anti-amyloid drug, but we will soon have anti-tau drugs. So we will be using maybe 2 or 3 drugs. And as I said before, cholinesterase inhibitors and memantine will remain as symptomatic treatment for Alzheimer's disease. Thank you very much.
Thank you very much, Dr. Lopez. Very insightful presentation. We're so fortunate and grateful to have you here at the University of Pittsburgh. Thank you to all of you for watching this Virtual Health Academy. Pitt Health Academy events provide unique platforms to showcase groundbreaking research and advancements in health sciences. For more information on upcoming events, please contact Alex Rigby, our Executive Director of Health Sciences Alumni Relations. Hope that everyone has a very nice holiday season. Thank you very much.
Thank you.